Hi, I'm Dr. Keith Robinson, Medical Director of the Medical Management and Scientific Services Group at Syneos Health. I am a board-certified pulmonary and critical care intensivist with over 14 years of clinical practice experience. I'm here to describe how healthcare professionals can use BiPAP devices to support ventilation in patients with COVID-19 and respiratory distress. The causative agent of the global pandemic, systemic acute respiratory syndrome, COVID-2, or what is commonly referred to as COVID-19, continues to spread rapidly across the world. Currently, there are no vaccines or approved treatments for the infection, which is known to cause, among other symptoms, pneumonia and acute respiratory distress syndrome, or ARDS. An estimated 1 to 3% of patients with COVID-19 will develop ARDS. The only intervention that improves survival in patients with ARDS is mechanical ventilation. The challenge presented to healthcare professionals across the world is that as COVID-19 continues to spread and as the total cases rise, a shortage of mechanical ventilators is anticipated across the globe. Healthcare professionals need solutions to deliver life-saving care to critically ill patients who will be flooding hospitals across the world during COVID-19 pandemic. Per the FDA CDC guidance, in the event of a ventilator shortage, the use of BiPAP devices to support ventilation is a potential emergency solution for COVID-19 patients experiencing respiratory distress. BiPAP ventilation provides a means to support patients in respiratory distress until a standard mechanical ventilator becomes available. In some cases, a BiPAP may be used in lieu of a standard ventilation. A BiPAP is traditionally used to support inhalation and exhalation in patients with chronic illnesses. However, a BiPAP device used to support ventilation in a patient with COVID-19 in respiratory distress should connect to an endotracheal tube. Which patients are candidates for ventilation support using a BiPAP device? BiPAP-supported ventilation can be used for patients who have tested positive for COVID-19 or those with results pending who are suspected to have the disease. In addition, patients with moderate ARDS, defined as a PF ratio of 200 to 100 millimeters of mercury, are candidates for BiPAP ventilation. Furthermore, patients should be hemodynamically stable with a SOFA score of less than 2. Finally, BiPAP ventilation can also be considered in patients with chronic illness, not in exacerbation. A BiPAP machine may be used in ST mode to provide ventilator support to an intubated patient in respiratory distress. The IPAP, EPAP, and FiO2 settings can be adapted to support the patient when a standard ventilator is not available. Pressure support applied by the device creates the tidal volume within the patient to aid ventilation. I will now describe how to adapt BiPAP devices to support ventilation in patients with respiratory distress who have been intubated. Set the IPAP to maintain a tidal volume of 6 milliliters per kilogram. For example, a patient weighing 55 kilograms, the tidal volume would be 330 milliliters. Note, this calculation should be based on ideal body weight. Once the appropriate tidal volume has been reached, titrate the EPAP setting to maintain an oxygen saturation of greater than 90%. If the FiO2 is at 100%, adjust the EPAP slowly at a rate of about 2 centimeters of water every 4 minutes. Keep in mind that the IPAP may also need adjustment to maintain the tidal volume. Please refer to the parameters outlined in the brochure. Use of BiPAP may delay or remove the need for mechanical ventilation in COVID-19 patients. The BiPAP cycles positive pressure with each patient-initiated breath. However, you can also set a backup respiratory rate to ensure the BiPAP delivers a minimum number of breaths per minute. Minute ventilation, or minute volume, is the respiratory rate multiplied by the tidal volume and reflects how sick the patient is and how hard they are breathing. Both minute ventilation and respiratory rate are generally high in patients with ARDS. The backup respiratory rate should mirror the patient's rate prior to sedation and intubation. In patients with ARDS, the backup rate may be set to 14 to 20 breaths per minute to maintain high minute ventilation in these patients. This helps to prevent the patient from feeling oxygen-starved or air-hungry. Once the patient has been stabilized on ventilation, the respiratory rate can be lowered as tolerated to maintain a pH greater than 7.3 as measured by arterial blood gas. It is important to maintain the lowest possible tidal volume while still supporting the patient. The plateau pressure should not exceed 30 centimeters of water. This is critical to prevent ventilator-induced lung injury and pneumothorax. AVAPS, or Average Volume Assured Pressure Support, is an algorithm-based mode for newer BiPAPs found in hospitals. The AVAPS mode provides functionality much closer to that of a standard mechanical ventilator. In AVAPS mode, rather than having a fixed IPAP setting, the BiPAP machine allows you to set a range for the IPAP. In ABAPs, enter the minimum and maximum pressures min-P and max-P. The IPAP will automatically fluctuate within this range so that, unlike in ST mode, the pressure support is not fixed. The IPAP fluctuates within this range in response to another setting, tidal volume. When you enter the patient's target tidal volume, a BiPAP in ABAPS mode will adjust the IPAP max to maintain the assured tidal volume. As a reminder, you can set a backup respiratory rate for the patient. Again, this respiratory rate must equal the patient's elevated rate prior to intubation. Once the patient is stable, the respiratory rate should be adjusted accordingly. Please refer to the parameters outlined in the brochure. Use of BiPAP may delay or remove the need for mechanical ventilation in COVID-19 patients. In conclusion, the rising cases of COVID-19 may result in a shortage of mechanical ventilators in hospitals across the globe. This video, in conjunction with the brochure, Use of BiPAP may delay or remove the need for mechanical ventilation in COVID-19 patients, provides a guide on how healthcare professionals can adapt BiPAP to provide ventilation. This conversion may offer life-saving alternative in the event that standard ventilators are not available for patients in respiratory distress. BiPAP use for ventilation has the potential to help save many lives in the face of this global pandemic.